I'll be speaking today about a very contentious issue. There's a piece of legislation that was put in by the Public Health Committee in the Connecticut legislature, SB 88, and it calls itself an act concerning aid in dying for terminally ill patients. And I'll be speaking to Nancy Allisberg, who is retired now, but was managing attorney at the state of Connecticut's Office of Protection and Advocacy for Persons with Disability. And she was also legal director of Disability Rights Connecticut. And we'll be speaking with Joan Kavanaugh, who is active with Progressives Against Medical Assisted Suicide and another group called Second Thoughts Connecticut. Good evening to both of you.
Good evening.
So first off, let's maybe talk about a definition. When we're talking about aid to terminally ill patients, we're not talking about painkillers. We're talking about giving physicians the legal right to prescribe substances which somebody who is, quote, terminally ill, unquote, might take to cause his or her own death. Is that right?
Yes, that's correct.
Okay. Well, Nancy, you wrote an article in the Connecticut Mirror just recently, and it was called Physician-Assisted Suicide, Second Thoughts. So why don't we talk about that? What is your feeling? You don't call it aid for, how do they put it, aid in dying. You call it physician-assisted suicide. So,
well, I'm calling it for what it really is, and that's exactly what it is. It's a bill that would give physicians the ability to prescribe medication that a terminally ill person could take to kill themselves. And even though the bill itself says that that's not suicide, as it's defined in the Connecticut general statutes, I think that you call it what it is. It's suicide, and that's merely a legal nicety to put in the bill that it's not suicide. That's precisely what it is, and it's allowing physicians to do that with legal impunity.
And I'm sure you agree with that, Joan, because you're in an organization with that name, People Against Medical Assisted Suicide.
Yes, I do agree with that. And that's why we call it that, because the euphemisms are Orwellian, actually, that they apply to this. And it's very, the reason we felt the need to form a group called Progressives Against Medical Assisted Suicide is because we feel that it's very important for progressives to take a strong stand against this. Unfortunately, there are a lot of progressives in the legislature who are supporting this. And to me, it's shocking that they would do this, given the history of discrimination that goes on in this country against people in the medical system, the elderly, the disabled, Black and brown people. I mean, that's documented. And already they are denied equal access to healthcare. Already people are being coerced in, if they're elderly and disabled, to make choices not to take care of themselves, not to have medical treatment. I experienced it with my mother. I experienced that level of coercion from hospital administrators and medical providers who did not want me to treat her because she had dementia. So yes, absolutely. It is suicide. And sometimes I even think we should call it medical murder.
Now, Nancy, permitting physician-assisted suicide would discourage doctors from thinking of people with disabilities as having a life worth saving. Could you explain?
People with disabilities have been devalued for a very long time. We can go back to Nazi Germany, when people with disabilities were sent away to concentration camps and killed. because they didn't want them to be part of society. They didn't want decent people to have to see people with disabilities. And even in our own recent history, when women gave birth to a child with some form of disability, families were urged to place these children in institutions so they'd be out of the public eye. And that's precisely what's going on now. Doctors in their training and in most of their practices do not have a lot of experience dealing with people with profound disabilities. And they are not taught about the value of somebody's life as a person with a disability. So we've all heard stories about people who are, for example, wheelchair users who will meet people on the street. Or I heard a story just today about somebody on an airplane, and the cabin attendant went up to him and say, if that ever happened to me, I would kill myself. That the life apparently without walking is a life not to be valued. And that's what we're up against when we look at physician-assisted suicide, a medical profession that's supposed to determine when someone is terminal and is supposed to determine when or if they have capacity to decide whether or not to take their own lives, rather than a medical profession that looks at people as individuals, as full human beings who have had full lives, and who have been, these doctors have not been trained how someone with a profound disability can use their life, can make use of assistive technology. We know of beautiful books that have been written by people who can't use their hands, who can't speak, but they can write beautiful books because of assistive technology. Most of the medical profession is not aware of how people with disabilities can live a full and valuable life.
All right, but you keep using the word disabilities. The bill uses the words terminally ill. Now, what about that?
People who have disabilities can become terminally ill as well. I'm talking about this specific subsection of the bill because this is the community that I've worked with for the past 22 years plus. And while there are difficulties that I have with the bill for other reasons, my personal focus and my professional focus has been on the detrimental effect this will have on people with disabilities, particularly if you look at people with disabilities with communication disorders. How does someone with a communication disorder, if the doctor doesn't know that they have a tablet that they can use to communicate with, cannot know that they might just use an alphabet block and spell out words, that they can communicate meaningfully with this person? How is the doctor going to be able to understand the value of their life? And when that person becomes terminally ill, because these lives have been so devalued for so long, it's so much easier for the medical profession to say, you know, we think it's about time, don't you? And that's what we're afraid of.
Well, this question of terminally ill to a layman may sound, oh, I guess that's cut and dried. But you had a program last year that we filmed. It's actually not such a clear standard, terminally ill. Could you explain?
Well, and in that program, you're talking about two people spoke that addressed that directly. Anita Cameron from Not Dead Yet and Dr. Andre Sofer from Young Haven Health. And both of them, Anita's mother, in fact, was diagnosed as terminally ill and lived for 12 years after that. She was put in hospice for a while, and she graduated hospice. And in Dr. Sofer, made it very clear that yes, doctors can say, well, we think this person may have 6 months to live, but that is not a hard and fast diagnosis or prognosis. People often outlive those terms. That prognosis. I mean, a lot of people survive much longer than that. My own grandfather, I think, when I've heard this story, was told that he had 6 months to live because he had a terminal heart condition, and he died like when I was 3. So he was told when he was a young man. So there is no, so to make, so that in and of itself is a misnomer. In addition, the truth of the matter with these bills is that they are incremental, and the people who are advocating for this bill, largely nationwide, are a group called Compassion and Choices. And what they do, I mean, they will come on Wednesday when we have the public hearing about SB 88, which is the current bill before the legislature here in Connecticut to make physician-assisted suicide legal. They will come to that hearing, Compassion and Choices, and they will praise it up and down for this quote unquote supposed safeguards that it incorporates. And they will also, within the same week, or within their program, they will go on to advocate for, in the states where this is already legal in the United States, relaxing those safeguards, making them more, much wider. The parameters much wider to allow for example, it's a move toward active euthanasia. Right now, the requirement is that you have to be able to self-ingest. Well, if you can't self-ingest and you're an ALS patient, for example, they're going to argue, well, that's not fair. So that's an argument in favor of active euthanasia, which is exactly what has happened in Canada. Active euthanasia is now legal in Canada, and it is being, the parameters are even getting wider up there. A person with depression, and I believe also any form of mental illness is going to be eligible for this as of 2023. Paula Panzarella actually found that out in her research.
So what about, I think maybe we should mute, we're not speaking because that we're getting some feedback. What about the case of a person who, got a illness, disease, whatever it is, pain is incredible. There's no real hope of that pain going away, and that person wants to be able to go to the doctor or go to his or her doctor and say, look, I'm done with, get me something. What's the harm with that?
Well, the harm with that is multiple. What the focus should be on, I believe, is palliative care. And the focus should be on improving methods of palliative care, and making it widely available to anybody. My understanding is that it's not true that most pain cannot be dealt with in a palliative manner, that it's far too easy. And as Joan is saying, it's becoming easier for the doctors to give up on trying to alleviate pain and to simply say, well, it's time. Another example of where there's an effort to loosen some of the safeguards is in California, where they are now trying to limit the 15-day window from where you make a request to where you can actually get the prescription to 2 days. 2 days. Talk about a rush to judgment. And another thing that's important to recognize is there's really not a lot of truth to this beautiful, gorgeous death where you're surrounded by roses and violins. I personally feel that because life is valuable, death should be hard. It shouldn't be made easier. And another concern that this all raises is, since the states have had such a hard time learning how to kill people humanely when they're receiving a death sentence or the death penalty. We're not a whole lot better at doing that with this kind of a medicalized death. So this idea of this beautiful death is something that very well may not happen. And I believe Oregon is the only state that keeps any kind of records with respect to people who actually request medications, take medications, and the kind of death that they end up with. So I think there is a lot wrong with making it too easy to die and taking away any incentive being mostly in the manner of therapy to help people live.
Now, does this affect living wills? I mean, are you against that, where somebody says, well, if my doctor thinks that they're gonna, put a feeding tube down me and, just sort of my basic functions would continue that way indefinitely, but I wouldn't have any kind of conscious life. Are you opposed to a living will that says, I don't want that?
The question of living will, I feel that anybody should be able to make their own decision about when to end treatment. Absolutely. A good friend of mine recently did that. And she had been fighting ovarian cancer for a year and a half, and she went home because it was not working. The treatments weren't working, and she died within a couple of days. She had morphine and she was with friends. I certainly, that's an absolute, that to me, that's a given. I do caution people to be careful about living wills, however, because they can be very easily, when you are given a living will, the format that you're given, it steers you to that option of no extraordinary measures. And that's the basic template for these wills. I had one, and then I realized, no, wait a minute. This does not convey what I want. So I wrote my own, actually. And it's very detailed. And I have 5 people that I have entrusted to be my healthcare representatives, should I not have capacity to make the decision. And what I have said is, they must really question very deeply and very much and very, very carefully any physician who says, or anybody who says, all right, it's all over here, there's no hope. Before they decide to withhold treatment. I want that documented. I want that known. And I think you have to be that careful in this current medical environment. I know you have to be that careful. I've experienced it. So I would really caution people to write their own advance directives, to not go with the templates.
Okay, but right now we're really not talking about living wills, but this legislation that would allow doctors to prescribe substances to kill people, supposedly terminally ill people who want this with sound. It's not sound body, it's sound mind who would make this decision. Maybe the last question, Nancy, you've changed your mind about this. You one time were for this. Could you explain perhaps maybe the history of how you changed?
Sure. Several things. And it was all a direct result of my work at the Protection and Advocacy for Persons with Disabilities and working with people with profound disabilities. At one point, I did believe in physician-assisted suicide. And I thought that, I should be able to control my own body. I should be able to control my own death. But I was working on a case where doctors had sued the state of Connecticut in order to get a ruling that providing medication did not constitute murder. And several people with some profound disabilities came to my office and asked to intervene in that lawsuit to say, we don't feel safe with physicians having that kind of power. And they explained to me how their lives have been devalued by physicians throughout their entire life. And they explained to me how doctors do not understand assistive technology. And they explained to me how they don't understand that some people who live with a feeding tube or who live with a respirator can live very long, full, and fulfilling lives. I then had another case where I represented a young man, a 14-year-old young man with profound intellectual disability who developed a treatable form of leukemia. And the hospital ethicist at the hospital where he had gone for treatment had recommended that he not receive treatment because they said he would not be able to understand why he was suffering the side effects of the chemo, and that the chemo might impair his intellect even further. Therefore his life wouldn't be worth living, and that he shouldn't receive treatment. We argued that violated the Americans with Disabilities Act because they wouldn't make the same recommendation against treatment for somebody who didn't have a disability. Mm-hmm. And so he was treated, he recovered, and was placed in a loving adoptive home. I have other cases where people's lives were looked at as not being valuable. I represented a woman who suffered a stroke as a result of a heart transplant and lost her cognitive ability to speak clearly. She could think, but she couldn't speak well at all. She made it clear to me that she wanted to live. Mm-hmm. She made it very clear that she wanted to continue treatment for her heart disease because she still needed to have immunosuppressant drugs for the heart transplant. The heart was fine. She had just had a stroke. Her family felt that because she could no longer speak, that they were going to order the withholding of her anti-rejection medications. Mm-hmm. We went to probate court and got a probate court judge to order that she receive the treatment. I had another woman with a profound intellectual disability who developed aspiration pneumonia. And her guardian, who was her brother, said that she should not receive any nutrients. There was a do not feed and a do not hydrate order for her. We went to probate. I got a probate judge to reverse that order. And she went back home to her group home and was very happy for many years. So I've seen what happens to the lives of people with disabilities when they're devalued and how they can literally be killed by doctors. And it made me decide that physician-assisted suicide was a form of eugenics for the kinds of clients that I served. And if it wasn't right for them, it certainly wasn't right for me. So I changed my advance directives. And I no longer have an advance directive that says that I don't want to be put on a respirator.
Okay. Well, we'll link to your article, Nancy, underneath the YouTube. And Joan, perhaps there's an organization that you're both active in. It's on Facebook. What's its name?
Second Thoughts Connecticut.
Okay, so people could find out more by going to that Facebook page. And Joan, I understand you're willing to get emails from people.
Sure. If people have questions and they want to get connected up with either Progressives Against Medical Assisted Suicide or the work of Second Thoughts Connecticut, we need all the help we can get, and I'd be happy to reply to people and put them in touch with the right folks. So my email is joan.kavanaugh@gmail.com.
And we'll have that up on the screen. Okay, thank you very much for talking with me. There's going to be a hot issue, and I understand the legislature is going to have a hearing on it right Wednesday, February 23rd. So thanks again for talking.
Thank
Thanks.
you.